Good morning to one and all, and welcome to the University of Louisville Neuroscience Grand Rounds. It gives me great pleasure this morning to introduce one of our new faculty in the Department of Neurology and the Division of Child Neurology, Dr. Cemal Karakas. Dr. Cemal Karakas is an assistant professor now with us, and he is the co-director of the Epilepsy Monitoring Unit at Norton Children's Hospital. Dr. Karakas completed his training in child neurology at Downstate University in New York City, and upon completion of his residency there, he went and did a 2-year fellowship at Texas Children's Hospital, one of the busiest pediatric epilepsy surgery programs in the country. After completing his 2 years of fellowship there, we were fortunate enough to recruit him to join us here at the University of Louisville. And in his current capacity, he is trying to build up things and stratify things in our epilepsy monitoring unit. He also is particularly interested in the area of neurostimulation and RNS and VNS. Dr. Karakas today will be speaking to us about continuous EEG monitoring in the intensive care unit, an area that has seen a great growth over the last decade, and an area that is here to stay because it is really redefining and contributing significantly to the care of patients in the intensive care unit. We look forward to hearing from Dr. Karakas today about the importance of monitoring in the intensive care unit. Thank you, Dr. Karakas, and welcome again to Louisville.
Thanks so much, Dr. Puri, for this nice introduction, and thanks so much for recruiting me to such a wonderful place. So today I'm going to talk about guidelines for continuous EEG monitoring in the ICU. And all talk is going to be about like, why do we need guidelines? Why do we need protocols? What are the indications for continuous EEG? So, and how long do we need to do monitoring? And I hope if I have still some time, I'll go over some of the qualification for EEG personnel, and maybe I'll go over a few slides for quantitative EEG. So, Neuro ICU monitoring. We know that the changes in neurological function may be difficult to detect in comatose or obtunded patients. So a lot of time, unfortunately, in the ICU, examination is going to be insensitive to small changes, especially if someone on a sedative medication or on paralytics. A lot of time, examination is going to be really useless. So the brain is going to be like a small treasure in a box that you have no idea about. So, and many brain insults have narrow treatment window, especially when it comes to seizure or any sort of hemorrhage or any ischemia. We are literally racing with the time. So we need a modality that would tell us what's going on immediately. And we would like to monitor brain function, of course, to prevent or quickly detect primary or secondary insults. And those can be either ischemia, expanding mass lesions, brain edemas, increased ICPs, or seizures. So the goal of clinical practice of ICU EEG is basically to improve the neurological outcome in critically ill patients. We would like to be able to rapidly diagnose seizures and any other neurological insults. And hopefully, once we diagnose, we would like to be able to communicate the diagnosis efficiently to treating ICU physicians, so we can institute appropriate therapies, and so we would like to be able to assess response to treatment. We would like to confirm efficacy of treatment, avoid over-treatment, and utilize resources efficiently and control costs. So when it comes to continuous EEG in the ICU, there are several different components to EEG. We have raw EEG, where we can look at the brain waves second by second. We can have video, where we can clinically where we can correlate the clinical behaviors with any sort of changes in the EEG. So then we can have this component of quantitative graphical displays. So a lot of time, it may be hard to go the whole 24 hours to understand whether there is like any seizure or not, or how many seizures is going on. instead of doing that, you can compress maybe like a whole 24 hours into just like a page of spectral data, and you can immediately have some idea about how many seizures going on. And in terms of the review should be frequently done, and interpretation is very essential for clinical decision making. The optimal would be the real time, not always possible, and frequent communication with ICU staff is paramount. So like any modalities, there are advantages and disadvantages. And when it comes to CEEG, it's pretty sensitive to brain function changes from a variety of causes. This can be either some sort of hemorrhage, bleeding, like ischemia, could be infection, inflammation, any sort of seizure. So you immediately can have some idea about what's going on. And this could be either through like some changes in the frequency, amplitude, you can see some asymmetry in brain functions. And the best thing about the EEG is that it is continuous. So it can be done for hours, for days, or even weeks. And you cannot, especially when it comes to like monitoring for ischemia or any hemorrhage or things like this, you cannot do like neuroimaging, like MRI type of things every hour, not even maybe every day, but you can do EEG for literally every second. So it has an excellent temporal resolution. You can see the changes second by second. And not only that, it has perfect spatial resolution. You can have idea about what's going on in both sides, and it can tell you the changes in like a lower level, basically. So, and unfortunately, like any other modalities, there are disadvantages as well. So a lot of time, and most of the time actually, is non-specific as to etiology. It's almost like you are putting your ear on the wall and hearing some noise, but it's you don't know what exactly is causing the noise. So either it is an ischemic change or a seizure or whatever it is. So you know that something is going on, but you are not sure what exactly is causing it. And it's pretty susceptible to artifacts and drug effects. And for those who have done epilepsy or neurophysiology fellowship, you would know that like almost half of the fellowship is all about really being able to identify the artifacts from the real brain waves. A lot of time, even a simple tap in the ICU, especially in the neonatal ICU, so it can look like seizure, and sometimes you may spend hours, you can pull your hairs to understand whether what you are dealing with is a seizure or some sort of artifacts. And it can be really expensive and labor intensive, and it is technically difficult to implement. So like doing 24 hours can cost more than $1,000. ACNS came up with guidelines for CEEG monitoring and EEG terminology, and all these guidelines are talking about like who should be monitored, what are the standard terminology to describe EEG, and there are guidelines in neonates, in children, in adults, and they had those reviews for indications, for basically personal technical specification and clinical practice. And those are mainly consensus statements. They are unfortunately not very well updated. The last time they revised was like sometime between 2015 to 2016. But still, like it's definitely better than nothing. We have something to work with. So now, why do we really need guidelines? Like you mentioned, ICU EEG is expensive and labor intensive. There has been marked increase in use, and like Dr. Puri mentioned, there has been a significant growth in recent years in continuous EEG use. And I'm going to show you some data about that. So there is substantial variability in clinical practice, even in established centers, even in the same center between different attendings, there is like a different clinical practice. One would order an EEG, and while the other one would not order, while one would order only for 1 hour, and the other one would like to order maybe longer, maybe 24 hours or things like this. And there is a substantial variability in availability of staff, in equipments, and there is a lack of high quality evidence. So for all this reason, we need to come up with guidelines. And this study is from 2013 and 2019. This data is a combination of those two papers. It's a nationwide inpatient sample base showing the number of ICU patients who had undergone continuous EEG. And this data shows you the number of patients using CEEG between 2004 to 2019, you see there's a significant increase, like more than 200% increase. And then there's like a almost more than 1,200 increase, 1,200% increase between 2004 to 2013. So that's a significant increase. So, and this data showed that continuous EEG cohort was more ill, but it was associated with reduced in-hospital mortality. And of course, if you were on continuous EEG for a long time, then it was lengthy, it was cost was more because, of course, you were more ill. And this data is from combination of these three studies. So those are survey-based studies. What they did, they sent the surveys to hundreds of different institutions, asking many different questions for EEG availability, remote reading capacities, quantitative EEG use, and number of continuous EEG that they do per month. So if you look at the EEG availability, sometime in 2019, almost 63% of institutions were able to do some sort of EEG, either as an in-house or an on-call person. So, and then over the years, if you see, like it went up to like 86% from 63%. And then looking at the remote EEG capacity, in 2009, there were like about 78% institution was able to do that, whereas in 2014, it went up to 95%. And quantitative EEG use also increased significantly from 34% to 52%. And sometime in 2009, so on about like 58% of the institution were able to do only up to 5 EEG per month, whereas if you look at the 2014, more than 50% of this institution were able to do more than 20 studies basically per month. So again, why do we need guidelines? Like we mentioned, there's significant variability in clinical practice, and there are so many different conditions for which we can do continuous EEGs. But we need to come up with those protocols telling us what are the indications for monitoring and what are our priorities. So ACNS, like I said, came up with this consensus statement in both adult and children. They are talking about indication and the personal technical specification and clinical practice in CEEG. And unfortunately, like I said, those review papers are based on expert opinions because there are no clinical trials or anything telling or saying which patient would benefit from a CEEG or things like this. There are no standardized literature review or grading system, and it recognizes lack of data on CEEG and outcome to develop evidence-based practice standards. So for those who are interested in reading those guidelines and consensus statements, especially ICU physician or EEG reader, you can go to acns.org. There under practice, you can go to guidelines and consensus statement, and you can find all sorts of different guidelines for neonates, for CEEG monitoring in critical care, or some of the other consensus statement on CEEG. And like I said, those guidelines are not very well updated. The last time they updated it either 2012 or 2015. So when it comes to indication for continuous EEG, there are two major categories why an EEG can be done. They could be either seizure related or non-seizure related. So for seizure related, it can be done for detection of subclinical seizures, whether it is non-convulsive seizures or non-convulsive status epilepticus. EEG can be done for monitoring treatment of those seizures, and it can be done for characterization of paroxysmal spells, especially in the neonatal ICU when they have unexplained like brady's and apneas or things like this. And EEG can be done for non-seizure related, especially ischemia, or detection of ischemia, especially in case of subarachnoid hemorrhages, where you would want to make sure that they are not having vasospasm-related ischemias, or if someone is on ECMO, you want to make sure that they are not having some sort of thromboembolic events, ischemias. So then you can do EEG for management of burst suppression in anesthetic coma. You can do EEG for assessment of level of sedation and following trance, and it can be done also for prognostication, especially for subarachnoid hemorrhage cases or for post-anoxic coma. There are certain EEG markers that can tell us whether the patient has a poor outcome or not. So now we said there's a significant variability in terms of clinical practice between different physicians. So to understand why people would do EEG, Dr. Gavala, and he actually was my clinical physiology program director. So in 2014, he sent the surveys to 151 institutions, and from each institution, one neuro ICU specialist and one neurophysiologist responded to the survey. And almost like all of the physicians said they would use EEG if someone has altered mental status and if they had seizure previously. So if they said they would use EEG for burst suppression for increased ICP, and they would use the EEG, about like only 20% of the people would use EEG for ischemia or vasospasm, and just a little bit above like 15% to 20% said that they would use EEG for diagnosis of increased ICP. But interestingly, none of ICU specialists said that they would use EEG for increased ICP diagnosis. So, okay, I mean, not every patient is in the ICU, unfortunately, is going to be able to have CEEG, and we have limited availability of equipment and staff. But then, we need to know like which patient are most likely to benefit from monitor, right? For that reason, we need to come up with protocols, and those protocols should be developed by both EEG reader and ICU staff. So continuous EEG can be done for patients meeting certain criteria, either based on disease or severity of illness. So the resources can be allocated to most critical patients. And also, we need to come up with those protocols so we can avoid inappropriate overuse of CEEG. And that unfortunately happens a lot. Even recently, like we had some patients who has like Lennox-Gastaut syndrome, who is having 15 to 20 seizures almost every single day, coming into ICU with some sort of infection and with the fever and everything. And patient is a little bit altered, and the physician is ordering EEG every single time this patient comes in. Well, do you really need to do EEG for that patient? Questionable, right? So instead of doing the EEG for those patients who are already established and having tons of seizures every day anyway, you probably need to do EEG for someone who is more critical and need EEG instead. And resources, the protocol should be adjusted for local resources and give evidence every time possible. So this study done in 1999 by Vespa et al. Showed that almost up to 50% of patients who were in the ICU had seizures, and up to 90% of those seizures were non-convulsive. And those patients either had no or minimal clinical signs, and they are often recognized late. And it also has been shown that even non-convulsive seizure can exacerbate brain injury. It can increase ICP, cause edema, it can cause ischemia, local hypoglycemia, it can release extracellular glutamate, and it can be associated with longer ICU stay and poorer outcomes. So this is a little bit a crowded slide, but here what it's shown is that common neurological, medical, and surgical conditions associated with high likelihood of recurring seizure on critical care continuous EEG. So there are so many different brain insults here, and if you have any one of those, and if you are an adult, your chance of having seizure is somewhere between 20 to 50%, and if you are a child, chance sometimes goes up to 100%. So this slide literally tells me that every single person with some sort of brain insult who comes in ICU should definitely have an EEG. It's almost like more important than like a cardiac monitoring. So then what are the risk factors for seizures in the ICU? So this data is taken from the combination of those three studies. So they looked at all those patients who were admitted to ICU and who had the EEGs, and they compared those who had the seizure versus those who did not have seizures. And it seemed like if you have one of those, then you are more likely to have seizures, including acute structural brain lesion, if you are younger than 18 years old, if you had a history of epilepsy, if you had the seizure before EEG was done, if you had some sort of ocular movement and coma, you are definitely more likely to have seizures. And if you had GPDs, LPDs, or burst suppression on the EEG, also you were more likely to have seizures. So just keep in mind, if one of your patients has one of those or some of those, they are more likely to have seizures. So Now talking a little bit about like evidence-based medicine, do we really need to have evidence there or not? So looking at the indication for CEG when it comes to seizure, we have so many different societies, including Neurocritical Care Society, European Society of Intensive Care Medicine, American Clinical Neurophysiology Society, and everything. So American Clinical Neurophysiology Society is really fan of EEG. They love EEG. They said, if you have any of this condition, please go ahead and order EEG. And Neurocritical Society suggests that EEG ordering is just class 1B evidence for any of those. And then ESICM was not really much fan of EEG, and I don't know what exactly the reason for why this difference happens. And I guess either they are not very well updated, or the data or the literature they reviewed was maybe different. That's why they are like seeing the continuous EEG for those as like level 1C or maybe up down to 2D class evidence. So EEG should be done if your patient has persistent altered mental status following successful treatment of convulsive status epilepticus or clinically evident seizure, and especially if they have acute supratentorial brain injury with altered mental status, or if especially altered mental status is worse than expected from brain injury, if they have unexplained or fluctuating altered mental status. So EEG also can be done if your patient is on some sort of paralytic medication, especially in case of hypothermia, ECMO, or severe cardiac diseases. So, and if you do just like a routine EEG, and if you saw some periodic epilepsy discharges, then you are more likely to have like non-convulsive status or status epilepticus. You should definitely do continuous EEG. And some of the other reasons that you should do, including episodic events suggesting possible seizure to correlate behavior with EEG changes. And those can be either subtle motor movements such as twitching, nystagmus, eye deviation, and chewing. And a lot of time in the ICU, patients are gonna all be like covered with the blankets and things like this. They are gonna have very subtle twitching and things like this. So you are not gonna be really able to understand whether they are having a seizure or not unless you really do a continuous EEG, see the brain wave. So nobody's gonna see whether they are having little twitching. So if someone also having some sort of episodic posturing, other paroxysmal or repetitive movements, if some unexplained autonomic spells, especially in the neonatal cases, or some unexplained paroxysmal increase in ICP, you can do EEG and try to understand whether those events are related to any sort of seizure or not. So, okay, perfect. So let's do EEG on everyone possible, right? But then how long are we gonna do the EEG? Are we gonna do for weeks, or just 1 hour, 4 days? So for this, and Dr. Hirsch, Lawrence Hirsch and Jette, they did this study where they looked at those patients who underwent continuous EEGs. They did that study retrospectively, and they look at the time to record the first seizure. And then they showed that if you order an hour EEG, you are just gonna catch only up to 50% of the seizure. But if you do the continuous EEG for a total of 24 hours, then you are gonna fully be able to capture up to 80 to 90% of seizure. And if you wait another day, like up to 48 hours, so the chance of capturing a seizure is gonna go up to 95%. So this tells me that if your patient had a seizure and now in altered mental status, and you are wondering how long I should do the monitoring, so please like try to order the study for at least like 24 to 48 hours so you can capture up to 80 to 90% of the seizure. And longer is definitely gonna be better if it's like 3 days or so. So this study is a pretty large study where they looked at 665 consecutive patients who had CEG over 72 hours. And it was based on multi-stage survival model. They looked at 3 different risks. So those were clinical risks, including either they had coma or not coma. EEG risks were whether they had epileptiform discharges or not, and the seizures, whether they had previous seizures or not. So they said, and this study showed, if you have no epileptiform discharges and you had the seizure and now you are comatose, then your chance of having seizure in 72 hours is about 36%. And you have to wait at least 14 hours, so your chance goes down to 5%. If you have epileptiform discharges in the EEG, you're comatose and you had a seizure, then your chance of having another seizure goes up to 64% in next 3 days. And you have to wait at least 44 hours, so your chance of having another seizure goes below 5%. So again, this study also tells me that if you order a study on someone who had a coma and had a seizure before, and now you are seeing some epileptiform discharges, you have to wait at least 2 days to make sure that you are not going to see any more seizures. So ACNS suggested that in adults, if someone has altered mental status but not comatose, you can do EEG for 24 hours, but if you are comatose, then EEG should be done at least for 48 hours. In children, regardless, please try to do it for 48 hours. And consider repeat or longer continuous EEG if there is an acute clinical deterioration after initial 24 to 48 hours, or if someone has been on anti-epileptics such as like midazolam, lorazepam, or this kind of sedative medication. As you are weaning the medication, patient may have some rebound seizure, so you definitely need to continue to do or repeat EEGs for at least 24 hours after sedation. Or in hypothermia cases, they also said do EEG at least 24 hours after normothermia. So the only way to confirm seizure cessation is with continuous EEG, right? So you may have a patient who came in with the convulsive seizures, right? And then you treated them and you would think, oh, patient now stop having seizure. Do I really need to order another EEG? Yes, you do. This study showed that even if you think that you successfully treated convulsive seizure, if you do continuous EEG, up to 14% of those patients are going to have still non-convulsive status, and up to 34% of those patients are going to have some sort of non-convulsive seizures intermittently. And doing continuous EEG is going to allow titration of continuous IV AEDs or other status epileptic treatment. So you can use the EEG to monitor for seizure cessation, for burst suppression, or complete suppression. So to confirm cessation of seizure, again, you need to do EEG for at least 24 hours. So in terms of, again, the evidence-based classification for monitoring seizure treatment, ACNS was again fan of EEG, saying that yes, go ahead and initiate CEEG and use the CEEG for treatment of status epilepticus and start EEG as soon as possible after status epilepticus. In this case, Neurocritical Care Society and ICM, they were not much fun. They saw this as like 1C class evidence. And ACNS suggested to do 24 hours at least doing EEG. So some of the other reasons that we can use the EEG for includes identification of ischemia, especially in case of subarachnoid hemorrhages, or if you are doing some sort of vascular, neurosurgical, or interventional radiology procedure, or in patient with hemodynamic lesions or borderline flows, especially in case of carotid stenosis and things like this. So to avoid any sort of clamping or anything, you can do EEG monitoring to avoid any sort of suppression in the brain activity. And in other patients at risk for in-hospital acute ischemia. So some of our fans ask us like, okay, when do we need to do subarachnoid hemorrhage? And I guess recently we had some patients who had subarachnoid hemorrhage and we didn't do, and we were asked like when we should have done, how long we should have done and everything. So if you have a patient with subarachnoid hemorrhage, then you should begin continuous EEG as soon as after clipping or coiling. If possible, get establish a baseline to know what exactly the baseline is looking like, and then afterward you can see the changes. So because risk of ischemia with the vasospasm especially is the highest between day 2 to 14, so it's the best to do the EEG between those days. And if you use only raw EEG to identify ischemia, you may miss ischemia because it's a slow process and the changes in the amplitude may be pretty slow, and especially if there are two readers from day to day reading the EEGs, so they may not be able to appreciate the changes, especially if they don't go back to previous day and look at the EEG, compare them. But if you use quantitative EEG, it's going to be much better in terms of seizure detection and ischemia detection in those cases. You can use alpha-delta ratio, you can use alpha variability or asymmetric indices, and I will show you some example with the quantitative EEG, how it looks like. when you have any ischemic cases, if I still have some time. So again, some other reasons why EEG can be used. So it can be used for pharmacologic sedation, because slow changes may not be seen on review of raw EEG. A lot of time we are going to need to use quantitative trend over times, and anesthesiology people use what's called bispectral index to assess the level of sedation based on different continuous EEG parameters. So, and especially in neonatal cases, drug effect can be additive to brain dysfunction. So you may not know much about like how much of altered mental status is because of the medication or because of some other changes in the brain. So it definitely, you definitely need some sort of EEG for that. So, and it can be used particularly in patients requiring paralytics, right? If you are using paralytic medication, patient is going to be completely like without any movement. Even if they are having any sort of seizure ongoing for hours, they are not going to have any convulsion or anything. You're not going to see anything at all. So anytime you have a patient in the ICU on paralytics, please make sure that they have continuous EEGs. And you can use the EEG for management of pharmacologically induced burst depression to avoid especially oversedation or cardiovascular depression. So if you are putting someone on burst suppression and all you need, if it's all just like 3 to 4 seconds of suppression, then you can, manage your medication accordingly. You don't need to suppress the EEG for hours and hours. So for that reason, again, EEG is very important. So, and another reason to do EEG is prognostication, especially in subarachnoid hemorrhage case or post-anoxic coma cases. So they show that if you have periodic epileptiform discharges, electrographic status epilepticus, absence of sleep architectures, those are unfortunately poor indicator for subarachnoid hemorrhage. And for post-anoxia, if you have burst suppression, alpha coma, microlung status, electrode cerebral inactivity, or periodic epileptiform discharges, then your chance of outcome is unfortunately going to be poor. So again, looking at some evidence-based indications for CEEG, ACNS, like always, was fun, saying that if you had any of this, please go ahead and order EEGs. But for some reason, European Society doesn't like the EEG for whatever reason. So in the summary, so there is substantial agreement across guidelines on many recommendations for ICU EEG. So almost all based on low or very low quality evidence, all the statements. And higher quality evidence is needed in order to provide stronger recommendations. And we need more standardized treatments, standardized research with like randomization, blinding, and if they are outcomes based and assessing the cost effectiveness would be the best. So now since I still have time, I'm gonna go over the qualification of CEEG personnel, and I will go over a little bit quantitative EEG. So ACNS suggested that any physician who is gonna be reading EEG, if possible, should be trained in the clinical neurophysiology and should have a fellowship training, either clinical neurophysiology or epilepsy, as far as they read like continuous EEGs for at least 3 months. And they should be board certified in either clinical neurophysiology by American Board of Psychiatry or Neurology, or they should be boarded by American Board of Clinical Neurophysiology. And they should have specialized training in continuous EEG equipments, recording, safety, troubleshooting. They should understand the effects of any sort of brain injuries or drugs on EEG activity, and they need to know the use, yield, and limitation of quantitative EEGs. So in terms of the technologies should be registered by ABRED, and they should have the certification for continuous long-term monitoring by ABRED, and they should have had special training for continuous EEG use, routine maintenance, troubleshooting, and they should have some idea about like ictal or interictal electrographic patterns. Now in Nordson, like in children's side, so we have maybe 5-6 technicians, and unfortunately only one of the technicians is certified. So all the others are either pretty new or they just recently started. So it is definitely important to educate and make sure our staffs are registered for better quality of care. So ICU nurses, they don't really need any specific training on EEG. Depending on the level of their involvement with EEG, they can do electrode placement, electrode removal, or they can use bedside trends. They are trained, especially in the quantitative EEG. So the monitoring technologists, they should be registered EEG technologists, but what kind of training is needed really is a question. So in terms of ICU EEG team and staffing, depending on local resources, of course, so we need EEG technologists. The best case would be to have technologists in-house all the time, but if not possible, at least we can have some on-call personnel. So we should be doing standard 10 to 20 placement, and we should be able to do urgent recording versus long-term recording anytime that's needed. And screening for EEG changes can be done by ICU nurses, especially with the quantitative EEG. They may not be able to read raw EEGs, but quantitative EEG is something that they can have some idea about. So technicians, neurology residents, clinical neurophysiology, epilepsy fellows, and advanced EEG technologists. And reading or screening should be either continuous, if possible, that would be the best case, or intermittent. And they should review the raw EEG and trend, whichever is possible, to identify any sort of changes and to make clinical recommendations. So when it comes to some technical requirements, we have different types of electrodes in the continuous EEG. So we have either discs or needles. So anytime we are using disc electrodes, if possible, they should be imaging compatible, because a lot of time those patients may need to go to neuroimaging, and you don't want to hook them on and hook them off again and again every time they need to go to neuroimaging. And electrodes should be disposable, if possible, for only one single use, especially in the COVID era. You don't want to use the same electrodes for different people. And in emergency situation, needle electrodes can be used, but this typically is not something that we commonly use. And there are other type of caps that can be used in the ICU EEG that can be applied quickly by nurses, even some students, if there's availability of those kind of caps, but I don't think we have those kind of caps in our hospital. So the electrode location should be based on international 1020 electrode placement system. We should have at least 8 electrodes, but 16 and more would be optimal. But if we have less amount of electrodes, then our sampling, and especially spatial sampling, may be inadequate, and we may not be able to distinguish artifact from the cerebral activity, or interpretation may be really difficult if some of the electrodes are dislodged, when especially you have only few electrodes. So there are different EEG machines that can be used in the ICU. They could be either fixed or portable with small footprints. They can be wall mounted, and they can be flexible, like kind of calls that can be taken to anywhere, any room. And anytime you have any EEG machine, a camera with video is definitely recommended, so you can correlate any sort of clinical behavior with EEG features. Because in the ICU, there's so many artifacts going on, you definitely need to know what's going on around the patient, so you can avoid misinterpretation of artifacts. So, and polygraphic data acquisition can be done through different modalities, including EKG, EOG, EMG, and all these are to help us to differentiate artifacts from basically brain waves. And so many other physiologic parameters can be used to correlate with any sort of changes in the EEG. So IT needs, so speed of the data review depends on the network speed. Remote reviewing can be done either in hospital, which would be faster, or outside of the hospital. So storage is a problem all the times, like 24 hours EEG can cost up to like 5 to 6 gigabyte or something like this. So, and security should always, the handling of this EEG should follow the HIPAA guidelines and everything for security. So now talking a little bit about like quantitative EEG, why do we need quantitative EEG and how it would help us? And for those who are expecting an EEG reader to give a report by 8 a.m., I just want to give you some idea about like how many EEG pages and things like this we go through. So in any 24-hour EEG study, right, there are like 86,000 seconds, okay? So, and in each page, when we look at each page is 10 seconds, meaning that we have to go through 8,600 pages when we read 24-hour EEG. And if you spend only 1 second per page, that's going to take you almost 2.5 hours to review the whole EEG without stopping a single second. If you look at 5 pages per 1 second, then you are going to need 28 minutes. This is in case when you don't have any seizure, no artifacts, no abnormalities at all, for which you have to stop and kind of try to understand what exactly we are dealing with. But if you keep stopping for any sort of seizure or abnormalities, this is going to definitely be more than an hour at least. Okay. So for this reason, we need to have some sort of modality that can indicate segments of EEG that may contain events of interest and that can increase the speed of review, basically. And hopefully something that can decrease the complexity, so even like a bedside caregiver such a nurse can look at it and have some idea whether the patient may be having some seizure or not, so they can immediately notify the EEG reader or neurologist in case like there's not enough technologists reviewing all the monitors. So unfortunately, there are no studies on sensitivity and specificity for seizure detection in the ICU when it comes to using quantitative EEG. And there are nearly limitless combination of trend type, electrodes of brain regions, and time display that you can use, for which the standardization is difficult. So, but the use of quantitative trend is always encouraged if possible, because you may detect gradual or subtle changes that are not visible with a review of raw EEG, and I'm going to show you some example. And anytime you are going to use quantitative EEG, it's not going to replace the raw EEG. You'll always need the raw EEG for sure, but at least it will increase the speed of review much faster if you have. So just an example of how a quantitative EEG looks like. So this is like a graphical display of a half an hour EEG basically. You can have so many different information. It can give you about like seizure probability. It can give you rhythmicity spectrogram. It can give you density spectral array. It can give you some idea about the asymmetry and the amplitude. So it will tell you, hey, look, there is an increase in seizure probability. And this is, imagine, this is just half an hour EEG. It's not like 10 seconds per page, just one page, but giving you data about total of half an hour. Then it tells you, hey, there's an increase in seizure probability. You look at this. So immediately you look at this point, there's an increase in rhythmicity in those frequency range, and there is like an increase in the power of those frequency, and there's an increase in amplitude. Okay, at this moment, you know something is going on, you click on it, and you immediately look at the raw EEG, and you see there's a seizure. Once you identify this as a seizure, and then you get to see there are so many of these looking exactly the same, and then immediately you know, okay, 3, 6, and 7. There are a total of 7 seizures probably going on within half an hour. You immediately know what's going on. So, and this is like 2-hour EEG, pretty much the same case. It tells you, hey, there's a seizure probability going on here. There's a significant increase in rhythmicity, significant increase in the power of these frequencies, and there's a significant increase in the amplitude. And you immediately look at it, and you know that this is a seizure, like not an artifact, because every time you see anything like this, you have to go in, you have to look at the EEG, the raw EEG data, because it can be an artifact. An artifact can also look like this. Once you identify this as a seizure, then you immediately look at it, and you immediately know that there are 7 seizures in 2 hours, without like spending hours and hours to review the raw EEG. And just another example, this is 8 hours. You can compress the whole 8 hours into just one picture. And then you immediately know how many seizures are going on. See, there's like several seizures over here, and the numbers are increasing more and more. And just another example, this is total of 24 hours. Here, again, you look at just amplitude. Amplitude is going up and down, up and down. It's almost like a burst suppression type of thing. And somewhere around here, it's almost becoming like continuous. And at this point, you know that patient is in some sort of status, because this is not stopping anymore, like after this point. So first 12 hours, patient had so many seizures on and off, but at this point, it became status. And imagine, like, you didn't need to spend half an hour to go over the raw EEG to get to this point to know, oh, patient actually was in status. Okay. And this is just an example of display where you have a computer with like so many different raw EEG for different patients. So each one of those are like different patients. And this is an example where you can look at the power ratio. And power, when I say power ratio, is the power of like alpha to over delta basically. So now you look at this point, power is all right, like going, it's kind of stable, but at somewhere around this point, it starts to go down, right? And at this point, you know that something is going on, decreasing the amplitude significantly. So imagine if this is like 24 hours, and this is initial 12 hours, and this is the second 12 hours, right? If an EEG reviewer, the first day, a person looks at here, and everything looks stable, that's fine. The second reviewer comes the second day and look at here, okay, amplitudes are all low, but that person doesn't go back and look at the previous EEG report or anything, and he would not know that there was a significant difference in terms of the amplitude. He may not be able to compare, but if he had this picture in front of him, and if he could have looked at this immediately, he would have immediately know that there is a significant decrease in amplitude and something is going on. So at this point, you should have immediately notified Neuro ICU specialist and saying that, hey, this guy is having some sort of ischemia or something going on. Please act on him immediately. Okay. So, and when you have so many EEGs going on, the best to have is a centralized monitoring. So you need to have a central monitoring session where you can have several monitors, where you have raw EEGs and video and quantitative EEGs all together. And in terms of staffing, there should be an EEG technologists and monitoring technologists basically monitor on this. So it can look like something like this, although in majority of the time you are going to have so many more computers, and in our EMU we have at least 3 times more monitors compared to what it looks like here. So what you can have for each patient, you can have a total of 4 monitors where you have like raw EEGs in one, and then a graphical display like a quantitative EEG in another monitor. You can have video here, and you can have some other stuff, maybe Epic or something like this in this. So that would be the best case to have. And or you can put like so many different raw EEGs from different patients together, and then you can have an idea about like what's going on immediately, like over so many hours. So review of EEG should be frequent enough to influence clinical management, and it should be done at least twice daily if possible. I mean, when you have 5-6 cases, you can do that easily, but when you have like 10-15 monitors running every single day, it may not be possible always to do twice daily, but at least once a day. So written reports daily. So internal verbal reports should be given to clinical team as needed. And remote review should be available. Like you should be able to review the EEGs from home, especially in COVID era, right? So the optimal would be to reviewing the continuously reviewing the raw EEG and quantitative trends and video by any sort of trained personnel. But is this possible? Unfortunately not. So according to I think AN and Medicare and everything, to be able to reimburse, you need to have at least 1 technician per 4 monitors. When you have like 10 monitors going on and only there is 1 technician sitting in front of all this monitor, and of course, like by the time you look from one screen to the other, 1 patient may have some seizure going on and you can easily miss it. So that would not be considered as continuous, okay? That would be considered as intermittent. And if you have 1 person for like 10 monitors, you cannot technically get reimbursed. So the communication with ICU team is very, very, very important. And the EEG reader should be able to gather information about clinical status of patient all the time, especially in terms of medication, mental status, internal procedures. Like if you know that patient is going some sort of procedure and they like loaded the patient with some sort of benzo and you immediately see some background changes, you're not going to worry so much, and you're not going to immediately call trying to find all these people to tell them, hey, something's going on in the EEG. But if nothing is going on, you know that this patient is not going to have any procedure, is not on any medication or anything, but then you see some changes in the EEG, then that means you immediately need to notify people because there's a significant change going on. That is not explained basically. And we need to provide reports which are clinically useful for ICU team. Timing depends on basically when they would like to get the report. The ideal is usually early in the morning before they runs. It could be either verbal or written. A lot of time we do through text. And there are cases when the EEG looks really complex and it's not easy to just like tell or communicate these findings to the physician. Then in those cases, you may need some face-to-face discussion with the responsible physicians. And education for ICU attendings, fellow nurses is the really most important. So what are the gold standards for ICU EEG? I mean, technically, it would be the best to have like 24/7 hour EEG technologies for reviewing, basically. And those people should be skilled, dedicated to EEG review. And like I was saying, there should be only fee monitor per one technologist, and if possible, to have quantitative EEG would be the best. And there should be a person who is on call all the time, pretty much day and night. So anytime, whenever there is any need for EEG interpretation, this person should be available. And because a lot of time the EEG reports are gonna talk about so crazy stuff, and ICU EEG team may not really know how to interpret the result. For this reason, having a neurology consult anytime there's an order for continuous EEG, I think is very, very important. So the conclusion is that ICU EEG is a rapidly evolving field. There's incremental steps in establishing causal chain between non-convulsive seizure and poor outcome, and frequent surveys of current practice has to be done. We have to establish and revise our guidelines anytime possible, and we need to come up with models for other collaborative clinical expertise and research groups in clinical neurophysiology. And those are my references. And that's it. Any questions?
Yes.
Are we going to be getting qualitative EEG?
Well, we are
really
trying to get the qualitative EEG. We are working on it.
So, Cemal, it looks like, no matter how one looks at this issue, that clearly if you are not monitoring patients, it looks like at least for the first 24 hours of, change in status, that, that there is a chance that you're missing, seizures.
Right.
And that if you do not have the resources to do that kind of monitoring, then maybe you're less likely to want to do it also. And I wonder if some of the reasons why the Europeans don't do so much, or don't suggest monitoring is because they are not as resourced in many areas. That's the impression that I got when I was at the recent International Neurology Society meeting. I got the impression that many places in Europe, several, really otherwise what you would think are very advanced European countries and things like that, they do not have that ability to do monitoring at all.
Right. I mean, if you cannot do monitoring, then you cannot have data. If you don't have data, then you cannot correlate, using EEG with outcomes and everything. Of course, then your evidence level is gonna be low, right? You're gonna just stay at 1C level or something like this. You're not gonna go beyond that. So, I mean, even in the USA, we have availability of doing all those stuff, but still, I mean, even for indications, there is no significant evidence-based, so all we have is just like at best maybe like 1B evidence. And they are mostly based on retrospective chart reviews and things like this. But in terms of the other point that you're saying, like if we doesn't matter how many people and everything we have, if we are not able to detect the seizures and everything, I mean, I think the most important thing, of course, is having a technologist. I feel like if you have a technologist sitting in front of the computer all the time, and if you can educate your technologist, and if they are able to identify the seizures, then I think the quality is definitely going to improve, because you can't do that. Like imagine you are running 24 hours of EEG, and then when you retrospectively review and you find out a patient had like a seizure hours and hours ago who was in status and everything, and of course by then, like if stats happen for half an hour or something, patient already had all sort of brain insult and everything, and of course like the outcomes is going to be poor. I mean, really the optimum would be to have a continuous monitoring. And for that reason, I feel like since we don't have like so many technicians, So if you can have at least the trend, the quantitative EEG, I think this can also take care of a lot of things, like because like some of the picture that I showed, I mean, in this case, let's say if you look at this picture, right? So a nurse may have no idea about how to interpret a raw EEG, but if she looks at this picture and if she sees those bumps over here, she's gonna know, hey, something is going on here. I should notify the physician. I mean, it could be something, right? So, and I think like having trend would significantly change the you know we look at the situation.
Cemal?
Yeah,
Cemal?
I can hear you, Dr. Kari. Yeah.
Yeah, very good, concise presentation. Now, one comment about the percentage of the patients who, over the time, 3 days, you reach point of 78 to 89% having documented seizures on the EEG. So it also means that at the start of the seizure EEG, the patient has not been seizing, and the first, say for example, the third day the patient had been seizing. That's what we found out. It may be detected because the patient is not improving clinically, and there may be some other underlying pathophysiology happening, and that's contributing to the seizure. So indirectly, the patient who is going to get better within the first day or two, their chances of having seizure is less compared to the patient who does not improve in those situations. So I think this is very, very important that we are talking about there are possible different etiologies playing a role, and we just have not treated or addressed, or that's why the patient is worsening, either sepsis or whatever injury-related swelling, which is usually going to evolve over the next 72 hours period. And we may record it.
Looking at this data, I mean, you can have intermittent seizures, right? You can be altered from the aftermath effect of the seizure, and then you may be in coma or maybe like altered, lethargic or whatever. And then if you have some of those features, like the risk factors that I mentioned about, if you have some of those, then your chance of having another seizure, it goes pretty high, and you sometimes have to wait at least like 48 hours or something to be able to capture another seizure, especially if you're having fluctuating altered mental status and things like this. So it is definitely very, very important. I mean, like at least 24 to 48 hours, I would say, at least 48 hours actually. I mean, they say 88% can be catched within 24 hours, but there's like 12%, right? It's like almost 1 in 10. So I would recommend everyone to get like at least 48 hours continuous EEG for anyone with any sort of like brain insult who steps in ICU.
Correct. So I was making a point that we need to have some clinical yardstick to indicate that this patient is probably more likely to have a seizure compared to the other, and that's what is documented there.
That's what it's here also. You know, they said if you have some of those risk factors, if you have an acute structural brain lesion, if you are younger than 18, if you had history of epilepsy, if you had a seizure before EEG was started, and if you have some of those, and if you do just like a routine EEG and you put some of those EEG features, then you're more likely to have seizures. So you should definitely do the monitoring longer.
Dr. Karakas, I could add something to that if I could, especially for the residents. This is Dr. Palade. Thank you for the presentation. For the residents, one of the physicians that was in the subcommittee that came up with the guidelines for continuous EEG monitoring was Dr. Hussein, who was at the time program director at Duke. They did a retrospective chart review of over 1,000 charts of patients that were found to have electrographic seizures on continuous EEG in the first 24 hours. And the reason they looked at the charts back was they're trying to identify what was on physical exam that was documented that could point to possibility of seizures or status epilepticus on EEG. And the two common findings, somewhat non-specific, of course, were pupillary dilation and upgoing toes. So if a resident, it's something very, especially upgoing toes was a reliable sign of seizure seen in the first 24 hours on EEG. So when the residents go and examine a patient, if you can document or check for that, they might give you an indication. I mean, it's so hard sometimes to look at a patient and, think, are they seizing or not? And we don't always have enough machines or technicians or capability to do it. But, and the other thing that confounds the problem sometimes is the use of propofol or Versed or other medications for sedation, in which case it's going to be harder to appreciate, if the patient improves, because they could be a potential anti-epileptic and weaning off that.
Exactly.
Send them
And also
medication.
depending on whether you are using like long acting or short acting. If you are using propionidazole and maybe short acting, you may need maybe like a short EEG. But if you are using phenobarb or pentobarb type of things, which has more than like week of like half-life, then that means that you have to put the patient on continuous EEG for literally like weeks.
That's correct.
Yeah.
Okay, thank you
And
very
I think
much.
the guy that you are talking about is Dr. Hussein. He's at Duke right now, and this was
Yeah.
one of the studies that he did.
Yeah, Dr. Hussein, yeah.
This morning, when I got up, I was playing the song, "Row, row, row your boat." When it's dark, and raining, that's very difficult to drive. So my drive up to was a pretty difficult one this morning.
Yeah.
You doing?
Yeah. And trying to manage a patient without EEG is almost like a driving in the dark. You know what I mean? Not knowing where you are going. Any other questions?
Well, yeah, there were parts where I had to.
That was very good. Thank you very much.
Dr. Puri?
Yes, Cemal?
Any other questions?
I think that was excellent. I think that was a very comprehensive talk about the importance from a clinical standpoint. You told us a little bit about the value of quantitative EEG, which I think we need to leverage more over here for sure, based also on what you're seeing. I think we need to leverage that a lot more. And I think you talked about some of the pitfalls that can happen and what we need. So I think that I think that this is an area with a lot of potential, and I think we need to use it appropriately. And by the same token, you can't burn out EEG text. You can't burn out people reading stuff. So I think that if we can get trends and look at trends and then base our treatment on that, it sounds like that may be a very, very good way to go also. So I think it was an excellent and thought-provoking talk. I thought it was absolutely fabulous. Thank you very much, Cemal.
Thanks so much. Okay, Dan.